Okay, so sorry, we're running a little bit behind. We normally give it 5 to 10 minutes just in case people are running late, but we're also normally set up during that time. There was a lot of traffic. So today we are continuing our class on street medicine. This is part of our ongoing resistance medicine course series, which is part of our crisis preparedness content, which teaches people to deal with acute and long-term instability and crisis in their communities. And there's a phone ringing where I am, so. Sorry, everyone. So, we are Sanctum of the Craft. We're an anarcho-socialist witchcraft collective. Amongst other things, we teach these crisis preparedness, resistance medicine, street medicine classes. All of it is available online for free. You can download all of it on our website. You can find it on our YouTube. You can find it on our Patreon in a free and public area. All of the PDFs, all of the EPUBs, all of the videos, everything to do with this portion of our content is free. Everything else starts behind a $1 paywall on our Patreon. You do not have to be witches to make use of our content. We welcome all who welcome all. We're intolerant of intolerance. This class today is specifically geared towards people who want to provide medical support to their communities, but it is welcome to everyone. Like, it's open to anyone who wants to take it regardless of their level of experience. Okay, let's get into the actual class. Let's talk about a closed wound. A closed wound is one in which the soft tissues beneath the skin surface are damaged, but there is no break in the skin. We are predominantly today talking about closed wounds. It is actually possible for blunt force trauma to create an open wound. It's possible for it to create a break in the skin, but today we're predominantly focusing on contusions, which are bruises. Most closed wounds are contusions, also called bruising. In a contusion, the skin isn't broken, but damage to the tissue still produces pain, leakage of fluid between damaged cells, and an inflammatory response. The inflammatory response results in redness and swelling. If small blood vessels in the dermis are broken, a mark that looks blue and black on most skin tones will appear. If larger blood vessels in the dermis are broken, a collection of blood underneath the skin may appear, called a hematoma, which looks and feels like a lump with blue, purple, and red coloration, but the coloration could also be black, brown, or yellow, depending on skin tone. Closed wounds can be mild bruising, but they also include more serious non-penetrating blunt trauma to important structures. A person with a closed wound where a lot of blunt force has affected their organs or bones may require urgent medical attentions. Bruising happens in combination with other injuries. So someone might have a bruise and also a laceration, might have a bruise and also a fracture, might have a bruise and also a rupture of something internally. We're going to talk about some of those today, and some of those fit into our other course content, like the class on lacerations. Closed wounds may also be present in combination, as I said, with open wounds. Blunt force trauma can still split skin. If any of you have ever dropped a really heavy box on your foot, you might have broken a small bone, gotten a massive bruise on the top of your foot, and also had a little place where it broke the skin. That's not uncommon. Yes. So, scene assessment. We teach an entire class on scene assessment and threat modeling and how to make different scenes safe for street medics. This is the shallow portion of it as relating to this topic. Anytime a medic encounters a person whom they intend to assess who has become injured, they should assess the scene before moving to assist that person. This can be done very quickly, but it is a vital self-protection step that also ensures they will be able to help the person that they actually want to assist. The source of a blunt force trauma might be something as innocuous as slamming a leg into a stool, but might be as hazardous as a falling building. A lot of the street medics that we have been training have been providing crisis relief for climate crises, where there have been floods and earthquakes and fires and things of that nature. So that would impact the scene that they would be entering. The first aspect of scene assessment is safety. A medic needs to check if it is safe for them to approach, if it is safe for the person who is injured to remain where they are, and if the danger to others is present in the area. So are others there who are also in danger? They need to check for environmental conditions that would make it unsafe for them to enter. The danger of more falling objects, fire, floodwaters, rapidly speeding traffic, approaching riot police. Whatever it is, they have to assess that danger when they move in to assist. If the scene is unsafe, they need to check if there's anything they can do to make it safe. If there's a fire, can they put it out? If there's traffic speeding by, can they put out flashers to redirect that traffic? A medic should never enter a scene if it will endanger their life to do so, but I'm never going to tell you that that is a hard and fast rule that you have to stick to all the time, because that would be wildly unethical and hypocritical of me to say, because I do it all the time. If the scene is not safe and there is a way to call for additional help to make it safe, the medic should do so as quickly as possible and provide assistance as soon as they can. Another aspect of safety is exposure to bloodborne illnesses. We're predominantly focusing on contusions today, the idea of a closed wound. However, it is still possible for a blunt force trauma to cause an open wound or for there to be blood in a scene with a person that you're trying to assist. Skin injuries may result in the medic being exposed to blood and other bodily fluids. With blunt force trauma to the abdomen, someone may end up vomiting. With blunt force trauma to the lungs, they may end up coughing a lot. Depending upon the severity of the bodily fluids that a person is encountering, the medic may need to use gloves, a mask, an eye shield. The medic should avoid contact with bodily fluids and any open wounds on their own body and to their own mucous membranes if possible. Again, we teach an entire class on safety and risk-aware PPE for medics. I'm not going to belabor the point here. If there's no other option and the wound is life-threatening, the medic may have to assist an injured person without adequate PPE. If the medic is exposed to blood from the person they are assisting and the person has an unknown medical history, this is not their child, their spouse, their partner, their medic buddy that they could sit down and ask these questions of, they should, as soon as possible, clean the affected area with soap and water and flush eyes, nose, or mouth with water or sterile saline. Then they should report that exposure to medical personnel and receive a medical evaluation, possibly including blood tests for both them and the source person to determine risk and potential necessary follow-ups. For example, they may be given post-exposure prophylaxis, a medication that can significantly reduce the risk of HIV infection. Patient assessment. The first step to assessing the injured person is to make sure that no immediate threat to them is present. So let's say that you as a street medic are stopping to help someone who has fallen and been beaten by the police. Are the police actively still beating them? That would be an immediate threat to their life and safety. Or if you stop to help someone who has been in a car accident, are they in a car that is on fire? That is an immediate threat to that person's safety. That has to come first. If they are at risk of gaining more injuries or dying, then you need to remove them from that risk before treating them for their contusions. The medic should assess the person's mechanism of injury, which refers to how an injury occurred, the forces involved, and the potential severity of that injury. In some cases, this is quite simple to assess. A fall where someone put their hand out to catch themselves, a broken bone from someone being pushed to the ground, etc. The injury may not be severe enough to cause more complex systems, and the assessment can proceed to how to manage the injury. In cases of more severe injury or injury from an unknown cause, the assessment is more complex. This can occur if someone has hurt themselves more severely or if the soft tissue injury is complicated by more complex issues, like being caused by a beating and thus involves contusion, as well as concussion or crush injuries or compromised airways, etc. The medic should rapidly assess if the individual is in an altered state of consciousness, if they have compromised breathing, if there is uncontrolled heavy bleeding, if they are exhibiting signs of shock, or if they are unconscious. This should be done by checking the person's external heavy bleeding, also called extreme bleeding, airway, breathing, circulation, disability, and exposure. To help you remember this is the XABCDEs. The medic should not focus on the contusions at first, but check for these other critical problems in order. So you can look at someone and be like, whoa, you are covered in bruises. But you start with bleeding, specifically extreme external bleeding. Is there severe life-threatening bleeding? If so, everything else stops while direct pressure is applied to the wound or a tourniquet is applied immediately. Airway. Is the person's airway open and clear? Are they choking or gurgling? If there's not heavy bleeding and they're choking to death, that comes next. Are they breathing? Look, listen, and feel. The medic doesn't need to count the exact rate of the person's respiration. Just check if it's absent, extremely slow, or very fast. Circulation. Do they have a pulse? The medic doesn't need to count it. Just check if it's absent, very weak, or extremely fast. Disability. What is the level of the person's consciousness? Are they awake and aware and able to respond? Disability is then followed by, are they alert? Are they responding to voice? Are they responding only to pain, or are they fully unresponsive? AVPU, alert, voice, pain, unresponsive. And their exposure. Carefully remove or cut away clothing to fully check the body for other hidden injuries. If someone is in immediate danger of bleeding to death, the rest of the assessment waits while that is addressed. If the pulse is absent, the medic needs to take immediate resuscitative measures. Moving on to the next assessment. After you've sort of scanned a person and been like, okay, you're not bleeding heavily, you are breathing, what else is going on here? A head-to-toe assessment should be performed after the XABCDEs to determine the nature of the person's injury. It should be performed in its entirety before treatment is begun, but should not be performed if the person requires immediate treatment for life-threatening injury, such as in cases of compromised breathing or severe hemorrhage. The responder performs a head-to-toe assessment to determine the location of all injuries, the extent of those injuries, and what treatment the person needs. There's a memory tool for this. It's not a very useful one, but it is still the memory tool that exists. It's called the DCAP BTLSs. The acronym guides a medic on what to look for and feel for as they check the body from head to toe. Deformities. Does anything look misshapen, crooked, or out of place? Contusions. Are there any bruises? Abrasions. Are there scrapes or grazes? Punctures. Are there any stab or puncture wounds? Burns. Are there any burns? Tenderness. Does the person feel pain when you gently press on an area? Lacerations. Are there any cuts or tears in the skin? And swelling. Is any area puffed up or swollen? Understanding the MOI, the mechanism of injury, what caused the harm, will help provide additional information on what injuries are likely. For example, a rubber bullet is likely to cause contusions, tenderness, and swelling, as well as possibly lacerations and even a puncture wound. So if the MOI is rubber bullet, the head-to-toe assessment will be informed by that information, and so will any treatment. If the MOI was that person was thrown to the ground and then a person knelt on their back between their shoulder blades, then bruising, possible fractures, and damage to the thoracic area should be suspected. So you inform your head-to-toe assessment and your DCAP BTLSs with the information you know about the mechanism of injury. Now, if you just find someone unconscious on the ground, you don't always know the mechanism of their injury. Patient assessment if they're capable of answering questions. Sometimes the medic knows the injured person, their family member, a housemate, a friend, a coworker, a volunteer they work with, or even another medic. Other times they are a stranger. Regardless, the primary concerns for assessing a conscious and communicating person are basically the same. First, obtain consent. Yes, even if the person is a member of the medic's family, they should still ask for consent to treat them. Secondly, prevent further injury. The shock from being injured, even if the medic perceives the injury as being minor, may cause an injured person and onlookers to pass out. It is recommended that the injured person be placed in a resting position. If there is any doubt as to how well the person is coping with their injury, they're dizzy, lightheaded, white, blanking in and out, that position may need to be fully supine, which means laying flat on the back, staring up at the ceiling or the sky. Bystanders may also need to be directed to sit or lie down if they show signs of presyncope, which is feeling as though they are about to faint. The medic should then obtain a brief description of the current injury and how it occurred. They should ask the person, are they dizzy? Are they lightheaded? Are they nauseated? Are they having any trouble breathing? You can gather information using sample. Sample is signs and symptoms. What are they feeling? Pain, nausea, dizziness. Their allergies. Are they allergic to any medications? Their medications. Are they taking any prescription drugs, especially blood thinners, critical if they're bleeding, or heart medications, critical if they're in shock? Their past medical history. Do they have any medical conditions that affect their bones, like osteoporosis or their bleeding? Their last intake. When did they last eat or drink something? And the events. What happened? How did the injury occur? If the person is bleeding, the medic... I'm just gonna pause here for just a second, because My co-teacher is, I can't go on without slides.
All right.
Everything okay?
Yeah. Sorry, where were we?
We're good. Okay. If the person is bleeding, the medic should ask about any medications that thin the blood or anticoagulants, or if the person has a history of excessive bleeding or clotting insufficiency. If they are showing signs of shock, they should ask if they're on medications that affect how their body handles shock, including beta blockers, calcium channel blockers, antidysrhythmics, and nitroglycerin. Because bruises can form on top of fractures, it is wise to do a quick assessment for possible fractures at the same time as examining bruises. To evaluate bruises and fractures, the medic should remember the 6 P's of musculoskeletal assessment: pain, paralysis, paresthesias, which is numbness or tingling, pulselessness, pallor, is it pale, is it gray, is it purplish, and is it pressured. The pressure refers specifically to both how the person responds to pressure and a feeling like the tissues are pressurized. When assessing pain, OPQRST may help medics remember the onset of pain, what provoking factors are palpating factors, what makes it worse, what makes it better, the quality of their pain. Is it sharp? Is it stabbing? Is it a sensation of pressure? The region of their pain. Where does it hurt? The severity of the pain. You can use the scale 1 to 10. Just keep in mind that it doesn't work for everyone. And the time, the duration of how long they've been experiencing it. Palpation of a bruised extremity should include the injury site and the regions around it, not just directly on the bruise, but around the bruise as well, to determine the scope of the injury. And something to be aware of is where the bruise forms isn't necessarily where the break is. Force travels through the body. So you can have a bruise and have the break actually be further up or have more breaks further up because force transfers. So just be aware of that. The medic should look for the signs and symptoms of major damage from a deep or serious bruise as they go over the entire area, paying special attention to instability, deformity, abnormal bone or joint continuity, displaced bones, crepitus, and reaction to pain. The medic should note if there is a change in pulse between an injured area and an uninjured area, because that can indicate arterial injury. If one limb has a pulse and the other one doesn't, that's not a great sign. Other signs of arterial injury include expanding hematoma, so basically a rapidly growing bruise, a vibration on the site of injury that matches the patient's heartbeat, and difficult to staunch bleeding. If you press on a bruise and you can feel that person's heartbeat where the bruise is, and the bruise is rapidly spreading, that's a sign of major internal bleeding. So let's say someone gets hit in the abdomen, we're going to get into abdominal trauma, and you're pressing around where the bruise is spreading and you start feeling a strong pulse and then there's no pulse in that leg. Guess where the pulse stops? Where the artery is torn. Okay. Any instability in the pelvic girdle should be communicated to emergency medical services as quickly as possible. If instability is found, the physical examination needs to be halted, as manipulation of the pelvic instability can disrupt blood clotting and worsen internal and external bleeding. So let's say that somebody had something really heavy fall specifically on their hips, and you're examining that bruising and you feel the pelvis shift in 2 different directions, like it's not fully connected anymore. Okay, you stop touching them and you contact EMS right away. Yeah, did you do the content warnings at the beginning of class in chat while I was in the...
No, we were rushing.
All right, we'll pause here and we'll put them where they don't belong. This class is very traumatic. There will be images of some of what we're talking about. I tried to find the least gory ones that I could. And we are also talking about bruises as a sign of both intimate partner violence and child abuse during the course of this class. So, lots of trigger warnings for today. If you need to step out at any point, step out, come back in when you feel ready. If you need to just be done, just be done. All right, moving on. The medic should always monitor and treat for shock, especially if the injury was caused by a bad fall, a beating which may have caused internal injury, or if there's any heavy bleeding under or through the skin. Children have a lower tolerance for injury than adults, especially blood loss. They may appear fairly stable and normal, though upset with good blood pressure and pulse, and then they just suddenly collapse. Children with fractures may not want anyone to see, touch, or splint the injury. Medics should always obtain consent from a parent, guardian, or caregiver if they are present before touching any major bruising, any broken bones. The parent, guardian, or caregiver may also have to be managed for their own upset reaction to the fact that the child is hurt. If possible, a parent can be asked to hold an injured child while they are being splinted, or while they're being band-aided, or while they're being examined. Pregnant people will naturally have a faster pulse, lower blood pressure, and often nausea, so evaluation can be complicated by that. We recommend that their symptoms still be taken seriously if they are present with the signs of shock, even if the signs of shock could be caused by them being pregnant, and that medics not automatically dismiss the altered signs of their medical state as being caused by them being pregnant. Sometimes clothing may need to be shifted or removed to make a head-to-toe assessment possible. In this case, the medic should ideally be the same gender as the person that they are assessing, but that is just not always possible. Cultural and religious beliefs regarding the removal of clothing and inspection of a person of another gender must be respected. We encourage that medics get cultural competency training. Clothing must never be removed without consent unless the person is unconscious and the treatment is needed to save their life. If someone is fully unconscious and you are trying to staunch their bleeding, concerns about the ethics of removing their clothing go to the wayside, but keep your touching to the minimum necessary to save a person's life. Okay. If the person's unconscious and unresponsive, the medic should always suspect brain and spinal injury and be very careful when handling the head and neck. The responder should go from the head to the toes while conducting a head-to-toe assessment. That's why it's called that. Checking the head, neck, shoulders, chest, arms, hands, abdomen, pelvis, legs, and feet in that order. The responder should look, listen, and feel for anything that is unusual. If they are uncertain if something is out of place or feels different, they can compare the potential site of injury to its mirror on the other side of the person's body or compare it to their own body. If you're looking at a big bruised collarbone and you're going, is that broken? You can touch the collarbone and be like, okay, well, on the other side, all right, that's different than this one. Or if you're looking at big bruise across both, you can cut your own collarbone. Be like, all right, that's what that's supposed to feel like. Yeah, that doesn't feel right. The medic should never attempt to cause new or additional harm while conducting a head-to-toe assessment. They should move a person as little as possible, as gently as possible, and with some care and basic compassion. If the person shows signs and symptoms of shock, becomes confused and unable to answer questions, or falls unconscious, or just straight up is unconscious when found, EMS needs to be contacted immediately. Signs and symptoms of a basic contusion. This is a basic bruise. Pain. More pain upon palpation. If you touch it, does it hurt? A lump or a bump. Heat. More pain when moving the area, and swelling. On white skin, this looks like, Ian?
Oh, sorry.
On white skin, this looks like redness, bluishness, greenish, or purplish color after the redness, and greenish or yellowish tone while healing, with some exceptions for abdominal injuries, which we'll show in a bit. On medium brown skin, this can look like darker red or darker brown skin and tends to have more red and yellow in the bruise than on people with whiter skin. On black skin, it can look like darker black skin or more brown and black in the bruise than on people with lighter skin. It is important for medics not to assume that all closed wounds are minor injuries. A closed wound caused by blunt force trauma may be severe, as there may be bruises on the internal organs and internal bleeding. Signs and symptoms of internal bleeding include, but are not limited to, pale or gray skin, moist skin, tender areas of the body, especially the abdomen, hematomas, a solid swelling of clotted blood, dizziness, lightheadedness, fatigue, weakness, shortness of breath, increased breathing rate, tachycardia, nausea, vomiting, vomiting of blood, coughing up blood, excessive thirst, confusion, presyncope, which is feeling like one is about to faint, syncope, which is fainting, seizures, loss of consciousness, and hemorrhagic shock, which we'll get into later. If the injury is to the head, the symptoms may include thunderclap headaches, changes in vision, confusion, weakness on one side of the body. If the injury is to the chest, the symptoms can include difficulty breathing, chest pain, and coughing up blood. If the injury is to the abdomen, the symptoms may include swelling, feeling full, bruising, blood in vomit, urine, or feces, and inappropriate bleeding from the vagina, outside the menstrual cycle or too heavy for a normal menstrual cycle. If the injury is to the bone, joints, or muscles, the symptoms may include bruising, swelling, and pain. If a person that a medic is assisting presents with signs of severe internal bleeding, they should be treated for shock while emergency medical services are called. Okay, we're about to get into bruises as a sign of abuse. If you all can't handle that, you can step out and I can come get you when we're done talking about intimate partner violence or child abuse.
No judgment.
No judgment. I also caution you on looking up some images of this online, because that was fun. When medics are serving as street medics to a community, including a group of the unhoused, it is possible that the blunt force trauma and contusions they will be examining and treating will be from some kind of abuse. That abuse may be from the systems of state power, such as the police, ICE, etc., but may also be from an intimate partner or a parent. Intimate partner violence includes mental and emotional aggression and abuse, progressive isolation, threats of violence, physical violence, and sexual violence perpetuated by someone who is, was, or wishes to be involved with the victim in an intimate, sexual, or romantic relationship. The violent actions are aimed at establishing control over the victim. The perpetuator can be any age, gender, sexuality, or race. They may belong to any ethnicity, culture, geographic region, religion or spirituality, sexual, socioeconomic background, or educational background. In cases where an adult in a relationship is being abused, if there is a child or children present in the place where the abuser resides with their victim, it is very likely that the child or children are being abused as well. Failure to recognize and intervene in situations of intimate partner violence helps to perpetuate that violence, which may lead to injury, permanent disability, and death. Intervention is difficult. Victims often resist help, and their autonomy cannot be further violated by attempting to force them to accept it when they don't want it or can't bring themselves to accept it. It may also endanger the medic to attempt intervention. Sanctum of the Craft recommends specific training for intimate partner violence intervention. We do offer it. We're not the only ones who offer it, though. You can go get training from domestic violence centers. Signs and symptoms of contusions caused by abuse specifically. So let's say you as a street medic start working with some of the unhoused communities in the area. There's a few encampments, right? And someone comes to you and they're like, hey, I need treatment for bruises. This is the difference between the bruises that we just covered and the bruises that you would notice on someone who is being abused. Cycles of aggression causing the medic to be called upon frequently with escalating severity of injury. If you keep being called back to help the same person over and over again, and each time the bruises are a little bit worse, that's generally a sign, because abuse escalates. It gets worse over time. Shorter intervals between injuries. Defensive, controlling, or overly solicitous behavior by the abuser. They often try and get you on their side, just so you're aware of that. Frightened victim. The victim refuses to talk to the medic directly and only talks to their partner, and the partner relays information to the medic. Characteristic injuries. Repeat and frequent injuries. Scrapes, lacerations, and bruises around the neck, face, head, trunk, and arms. Cuts, bruises, and fractures of the face and neck. Bathing suit pattern of injuries. This is bruises to the parts of the body that would normally be covered by clothing. And I don't mean like clothing like I'm wearing like shorts and a tank top. A bathing suit would cover it. Bruises and cuts from biting specifically. Restraint injuries. Bruises and friction burns from rope, zip ties, handcuffs, or fingertips. Welts and bruises in the outline of weapons, especially belts. Defensive injuries, injuries to the back of the body while being attacked, while being crouched on the ground, protecting the head and face, generally located on the soles of the feet, the back of the head, and the arms, as well as injuries on the palm and lower arms from attempting to block blows and broken fingernails. Cigarette burns, injuries while pregnant, multiple injuries in various stages of healing, inconsistent explanations for the type and severity of injuries, injuries anatomically inconsistent with the described mechanism of injury, explaining injuries as being from clumsiness, embarrassment and or evasiveness when questioned, delay between the time of injury and seeking treatment. They may wait several days before seeking help. Comorbid signs and symptoms are chronic pain, self-injury and suicide attempts, anxiety, depression, PTSD and CPTSD, STDs and STIs, pelvic inflammatory disease, chronic pelvic pain, chronic recurrent UTI, vaginal and rectal injuries, eating disorders, sleeping disorders, gastrointestinal disorders, frequent pregnancies, pregnancy complications, and substance use. It is important, if a medic thinks the person that you're treating for bruises is being abused, to try and see them one-on-one. If that is not possible, they may be able to slip the person a prepared small piece of paper with information on local resources that can help them. During assessment, they need to assess for immediate safety and the possibility of the person needing immediate help. Examples of intimate partner violence assessment phrases. As a medic, I ask everyone I see about their health and safety. Violence is very common. Can I ask you some questions related to violence? Are you ever afraid of your partner? In the last year, has your partner ever threatened to hurt or harm you? In the last year, has your partner ever hurt or harmed you? I'm concerned about your health and safety. Help is available. It is not your fault. You don't deserve what's happening to you. What can I do for you? How can I help you? The medic should have an understanding of the local resources available so they can formulate a safety plan with the person should they admit to the abuse and ask for help getting out. There is a 24-hour domestic violence shelter located in Raleigh that has a pickup location that you have to be to at a certain time every single day. And if you are not there at that time, they don't take you to the shelter. So that's something you should know. Like, you should know where it is, what time it is, and how to get someone there. The most dangerous period for a person getting away from the person abusing them is right as they are leaving. This is when the abuser often escalates to the very height of their violence, including threats of self-harm and suicide, stalking, the threatened use of weapons, hostage-taking, and murder. We recommend that medics know a 24-hour safe room, a location established by some hospitals, communities, and shelters, and try to get the person there. If a community doesn't have one, it may need to be established through collective action and mutual aid. If the person chooses to remain in the abusive situation, they should still be provided with lists of resources. These can include referrals to local clinics, mental health providers, and intimate partner abuse resources, advocates, shelters, etc. Victims often stay in abusive relationships for several years before securing help and actually leaving, anywhere between 2 years and as long as 7. I stayed in mine for 10. It happens. They stay a long time. Victims often make multiple attempts to leave, with the process hampered by fear, isolation, and economic or safety concerns. The medic should never attempt to pressure someone into leaving. Failing the person being willing to leave, the medic should document everything about the assessment and keep track of that documentation in case the person chooses to pursue legal action later. This documentation needs to include the date, the time, the location, as well as detailed descriptions of the person's appearance, their behaviors, their injuries, their health complaints, and their own words. If there were any other witnesses, their accounts should be recorded as well if possible without violating the privacy of the abused person. Their records must be kept confidential until the victim requests that they be given to someone else. The documentation should never, ever, ever use the phrase alleged, which implies that the medic doesn't believe the victim. This can be used against them later in the legal process. Their injuries are no more from alleged abuse than the injuries caused by a police baton. Don't hem and haw in your records. If you believe, as a street medic, that you are helping someone who's in an abuse situation, you don't write down, they alleged their partner hit them. No, they said their partner hit them. In cases where the abuse was due to state violence, such as during detainment or imprisonment by a police officer, ICE agent, border patrol officer, prison guard, immigrant detention facility guard, etc., the abuse needs to be documented using the steps outlined in our guide on documenting state violence-related injury. There's a specific way you document that kind of abuse in order to pursue legal action against the state. Victims of abuse should also be screened for non-suicidal self-injury and suicidal ideation, and again, we have a whole other guide on that topic. I don't have time to get into it today. Abused children. Trauma is the leading cause of death for all children, including both non-accidental, abusive, and accidental trauma. Abuse is the leading cause of trauma-related fatalities in children younger than 4 years old. Motor traffic-related injury trauma is the leading cause above 4 years of age. Bruising is the most typical manifestation of physical abuse in children. It is going to be generally the first sign. Unusual bruising. 1/3 of children with near fatal or fatal abusive injuries have previous medical assessments in which bruising was documented by emergency room people. Bruising from play and sports is common in children, which can mask an abusive environment. Bruises from accidents in play or sports are most often on the front of the body, over bony areas like elbows, knees, ankles, and knuckles, on the extremities, the lower legs, and the lower arms in particular. When accidental bruising is found on the head and face, it is normally on the forehead, although there are some exceptions. Bruising on infants should be particularly noticed as infants are not yet playing or engaging in sports, which would cause accidental bruises. Children's anatomy is different than adults. This is relevant for all of the bruising information, including this section on abuse. Children are more vulnerable to thermal shock from bleeding due to lower blood volume, higher body surface area to overall body mass, and less subcutaneous fat, and having thinner skin. The chest wall is more vulnerable. They are more likely to suffer from pulmonary contusions, which are lung bruises. We're going to get to those in a minute. Even from really minimal blows to the chest, their lungs can still get bruised. Children's abdomens are larger in size compared to the rest of their bodies, with underdeveloped musculature and relatively larger abdominal organs compared to the rest of their bodies. They are more likely to suffer organ injury from blunt abdominal trauma. The skeleton isn't yet fully calcified, which causes their bones to be more pliable and leads to a greater chance of fracture from impact trauma. Children's heads have a larger surface area that is prone to significant bleeding, including hematomas. The cranium is also thinner and it transmits energy really easily. Blows to the head are very serious in children, with skull fractures being common. If there's a big bruise on a kid's head, you should suspect a skull fracture and suspect that that is a serious injury. Head injuries in infants are especially concerning. If an infant is presented to you with a big bruise on their head, that is an ER visit. Their brains are more prone to shear and acceleration and deceleration forces. A hit to an infant's head can kill them because their brain moved around in their skull. So you have to take bruises on the heads of infants and children very seriously. Infants and children have less calcified vertebra, more lax spinal ligaments, and weaker supporting musculature, which can cause greater injury from blunt force trauma to the neck and back. So if a kid's been hit here, in this region, you need to assume it is serious. Signs and symptoms of abuse in children. Clusters of bruises, larger and more numerous bruises, bruises to the back of the hand or to the buttocks, repeat and frequent injuries, scrapes, lacerations, and bruises around the neck, face, head, trunk, and arms, cuts and bruises and fractures of the face and neck, that bathing suit pattern we discussed earlier, bruises and cuts from biting, restraint injuries, bruises and friction burns from rope, zip tie, handcuffs, fingertips, welts and bruises in the outline of weapons, especially belts, defensive injuries, we covered those earlier, the exact same as for adults, cigarette burns, multiple injuries in various stages of healing, inconsistent explanations for the types and severity of injuries from an adult explaining them or from the child explaining them, injuries anatomically inconsistent with the described mechanism of injury, explaining injuries as being from clumsiness, embarrassment and evasiveness when questioned, delay between the time of injury and seeking of treatment. The adults may wait several days before seeking help because they believe it will mask the fact that they are the ones who caused the injury. Comorbid signs and symptoms: low body weight for their age, low height for their age, lower verbal and quantitative skills for their age, failure to thrive, parental neglect syndrome, speech disorders, bedwetting, headaches, chronic pain, self-injury and suicide attempts, anxiety, depression, PTSD and CPTSD, eating disorders, sleeping disorders, gastrointestinal disorders, substance use, yes, even amongst children. Gastrointestinal disorders, substance use, behavioral difficulties, mimicking of abusive behavior, aggression, hostility, and acting out. It is extremely difficult if not impossible and potentially unethical, for a medic to assess a child without a parent or guardian or caregiver present. If the abusive parent or guardian is present, it is difficult but not impossible to assess a child for abuse. You have to not let on that that's what you're doing. You can ask lots of details like, hey, tell me how you got this injury. Were you playing? What happened? And just let the kid ramble. The most important part of doing so is to not further violate the child's sense of safety and autonomy. Make sure you get their consent for every step. Ask before touching, ask before prodding. Don't lie to them. Be very clear if you're going to touch a bruise, this is going to hurt. Okay? Don't tell an already abused kid this isn't going to hurt and then hurt them. Don't do that. The medic's assessment will have to include watching for the signs and symptoms of abuse and documenting them. You need to do all the documentation steps we covered with the adults, except that they may have to take that documentation to Child Protective Services. You should be aware that in North Carolina, all medics are considered mandatory reporters. If you suspect that someone is harming a child, you legally have to tell on them. You have to. Yes, question?
I just have a question. Is it public who reported them to Child Protective Services?
No, you can report anonymously. You do need to be aware that CPS has a history of taking children away from Native American, Black, and immigrant families and placing them into worse circumstances. Medics will have to investigate and determine what is best for the child, not for the community. But for example, if the child will be taken and detained by ICE in a concentration camp, then there might be an intervention other than getting law enforcement involved. Does that make sense? Okay. You have to make the decision you can live with. They may also be able to intervene with the parents, grandparents, or community to get help for the family. When we eventually present our class on intimate partner and familial violence at this location, we will get into some options you can create in a community when it isn't safe to get law enforcement involved. Because you can't allow a child to continue to be abused, but sending them to an ICE facility doesn't protect them from abuse. Okay, basic treatment for minor bruises. For minor blunt trauma, such as bruises and aches, rather than deep tissue bruising, broken bones, or internal bleeding, medics can apply or instruct the person to apply cold compresses. They should be wrapped in a thin cloth before being applied. It took me so long to find this image because I looked up cold compress on bruises and it was bare skin, bare skin, bare skin, bare skin, bare skin. No, at least put a paper towel between them. Were you taught this growing up? Don't put an ice pack directly on your skin? Okay, I got at least one nod. Don't put an ice pack or a cold pack directly on your skin. Put something in between them. Something thin, yes, it can be a towel, it can be a t-shirt, but something. Right, they should never be applied directly to the skin. They should be used for 15 to 20 minutes at a time, multiple times per day, over the first 48 hours, which is when they are most effective. A person can treat with the internal use of over-the-counter anti-inflammatories and pain relievers. The injured person can also ingest herbal anti-inflammatories, pain relievers, and muscle relaxants. These include, but are not limited to, white willow bark and valerian. There's an herbal section at the end of this guide. They can also apply topical anti-inflammatories such as Voltaren and comfrey-containing cream. They can apply topical pain relievers such as lidocaine and arnica gel. If possible, and it does not cause additional pain, the injured person can elevate a bruised extremity to reduce swelling. Okay, before we get into more severe injury, talking about blunt force abdominal trauma, any questions on what we've covered so far while I grab a sip of water? We are also at the halfway point if anyone wants to take a quick break.
Want me to pick up?
All right. It's gonna fall. Blunt force abdominal trauma. Before I get into this, I want to note I decided to leave out brain contusions, bruised brains, and put that in the class on head trauma because you as a medic are not going to be able to determine whether someone has a concussion or a bruised brain. You just can't. and you won't be able to, from an assessment, know for certain exactly what kind of head trauma someone is dealing with. They have to be seen by EMS. So yeah, we're not gonna get into that in this class. Blunt force abdominal trauma. Abdominal trauma is present in approximately 1/4 of major trauma incidences in the ER. It is also the leading cause of unrecognized fatal injury in children, which means it was found post-mortem. Abdominal injury from blunt trauma caused by a direct blow to the abdomen can be deadly, and it often goes undernoticed. The spleen is the most commonly injured solid organ, followed by the liver and the kidney. Abdominal trauma can be caused by blunt force impact, but also by acceleration and deceleration. So it could be caused by a steering wheel impacting someone, but also by like the rapid change of speed in a vehicle as it crashes. Blunt abdominal trauma can happen when the forward motion of the body stops and the internal organs continue their motions, which causes tearing inside, and then they slam into something. So you might actually have a combinatory injury. It can also be caused by crush injuries when the abdominal contents are crushed between the front of the body and the spinal column. The kidneys, liver, and spleen are at the greatest risk of injury from this. It may also be caused by compression from a direct blow or being slammed into a fixed object. The compression can deform hollow organs and actually rupture them. This is more likely to happen to the small intestine or to the diaphragm. Organs such as the stomach and intestines may also spill their contents into the abdominal cavity, causing a major risk from bacteria, acid, and more. Enough force transmitted into the uterus, the bladder, the intestines, the stomach can actually pop them. Just so you're aware. Which, if we have time after class, I'll tell you my silly story of my major abdominal trauma that was caused by the most ridiculous thing, and no one believed me that it was a problem other than my great-grandmother until I was in the ER and getting checked over, and it turned out to be a major issue. But yeah, it can happen from really silly things. Anyway, signs and symptoms of abdominal trauma: swollen abdomen, pain when palpating the abdomen, pain when the organ is palpated, rapid shallow breathing, contraction of the abdominal muscles, a guarded posture curled around the abdomen. They don't want to straighten up. That's generally a good sign. A Cullen's sign, which is a purple, blue, black, or yellow-green bruising around the belly button that indicates bleeding in the abdomen, often signaling severe acute conditions. Peeing blood, bleeding from the anus, bleeding from the vagina that is not adequately explained by menstruation, the signs and symptoms of internal bleeding. Because of the danger of abdominal injuries, assessment has to be performed very quickly. Delays in recognitions of the signs and symptoms may be deadly. Hemorrhage is a major concern in people with abdominal trauma, and they may die from internal bleeding if care is delayed. Abdominal trauma may cause respiratory distress that requires the medic to provide CPR until EMS can arrive. Because most abdominal injuries will require imaging for accurate diagnosis and treatment in an emergency room, the primary goal of the medic is to assess whether or not people need rapid transport to the emergency room by emergency services, or whether they can wait a while and see what develops. They need to determine if a person is suffering from severe internal bleeding due to the blunt trauma to the abdomen, stabilize the person as much as they can, treat them for hemorrhagic shock if they are hemorrhaging internally, and wait for EMS. Okay, any questions on that before we move on? Non-penetrating thoracic trauma. Thoracic injuries, injuries to the chest, it's just a fancy word for that, can be open or closed, caused by penetration or caused by blunt trauma. Thoracic trauma causes about 25% of deaths due to trauma in the United States. Many chest injuries cause death during the first minutes or hours after the trauma. Thoracic injuries are frequent in children. About 5 to 12% of pediatric trauma admissions in the ER are due to chest injury. As we mentioned earlier, the lungs and the heart are more vulnerable on children than they are adults. However, they are the second leading cause of death in trauma-related deaths in children after closed head injuries. Most thoracic trauma is due to car accidents and sporting injuries. However, firearms, abuse, and beatings by other police, ICE, etc. can also be among the causes of blunt trauma to the chest that causes death. The first kind of thoracic trauma we're going to talk about is pulmonary contusions, which just means that they have a bruised lung. Pulmonary contusions can cause interstitial edema, the abnormal accumulation of fluid within the tissue spaces surrounding cells in the lungs. So basically, they cause fluid to build up in the lungs until you are essentially drowning. They may also cause diffuse alveolar hemorrhage, which is a life-threatening, often acute condition where blood accumulates in the alveoli of the lungs. So then you're drowning in blood. People with severe pulmonary contusions may develop acute respiratory distress syndrome, which is called ARDS, a severe life-threatening lung injury causing rapid fluid buildup in the alveoli, the air sacs, preventing oxygen from entering the blood. They may also develop non-cardiogenic pulmonary edema, the acute accumulation of fluid in the lungs alveoli caused by an increased vascular permeability or damaged vessel walls rather than from heart failure. Patients who have a contusion greater than 20% of their lung volume have up to an 80% of risk of developing acute lung injury. So the bigger the bruised area, the more of a concern. If it's a small bruise to a lung area, less of a concern. Not a concern. How fast was that object moving? How much force transferred into the body? But generally, like a rubber bullet hitting in this area, it's going to hurt. They may cough. They will recover. But how close were they to the rubber bullet?
Right. I'm also going to add a caveat to that. If they used the rubber bullets properly and shot them off the ground from medium to long range, less of a concern. If they did what they're doing and just pointed it at someone and pulled the trigger,
more of a concern. Yeah. If it was pointed directly at them, if they weren't very far away, more of a concern. The bigger the bruised area of the chest, the more concern. The more force was relayed, the more concern. So a baseball bat, even if it's a smaller bruise, still a big deal. Okay. There are two stages of pulmonary contusions. First, there's an injury. Then there is an accumulation of fluid in the lungs. People may not realize their lungs are having any issue for 4 to 6 hours after the injury. They may not feel symptoms until after the accumulation of fluid in the lungs has begun impacting their breathing, which can take hours for them to notice. Additionally, even imaging of the lungs prior to the accumulation of fluid can find that there's no signs or symptoms of pulmonary contusions because the fluid hasn't accumulated yet to show on the imaging. Imaging needs to be repeated over several hours after blunt force trauma to the chest. I have worked at medic things where someone had a major blow to the chest, went to the ER, told them, got imaging done, was told there was no problem, went home, 6 hours later contacted me and was like, "Hey, Akima, I'm coughing up blood." It's like, back to the ER. And they were like, "Well, we already imaged him." So I shouldn't have to tell you your job, but I'm gonna, because I'm here. And having to tell them, well, yes, but the fluid hadn't accumulated yet. So be aware that, yes, it's a good idea to go to the ER right away after major chest trauma, but the symptoms might not show yet, and that person should really be held there for 4 to 6 hours. Now, lately, ER wait times are 4 to 6 hours, so there you go. Signs and symptoms of pulmonary contusion. Chest wall contusions, bruises on the chest, chest pain, resistance to airflow when breathing. It's hard to get the air into the lungs. Coarse sounding breathing, decreased lung elasticity. If you can't fully fill those lungs, that's a sign. Increased work to get enough air. Tachypnea, which is rapid, shallow breathing, typically exceeding 20 breaths per minute in adults, higher in children, often signaling underlying respiratory distress. Hypoxia, which is a critical condition where body tissues are deprived of sufficient oxygen, causing symptoms like shortness of breath, confusion, rapid heart rate, and blue-tinted skin. Hypercarbia, which is an abnormally high level of carbon dioxide in the blood, usually caused by hypoventilation, inadequate breathing, which causes confusion, fatigue, and loss of consciousness. Presyncope and syncope, so they feel like they're going to pass out, and then they do pass out. Respiratory acidosis, which is a condition where the lungs cannot adequately remove carbon dioxide, which alters the blood pH, dropping below 7.35. It is caused by hypoventilation due to airway restriction, which causes fatigue, confusion, and lethargy. Cardiopulmonary decompensation, a life-threatening, sudden worsening of heart function, which leads to heart failure. If you can't breathe, do you live through that?
Not usually.
So one of the symptoms of this is death. It is best for a medic to assume that there will be more severe symptoms caused by a pulmonary contusion if the impact was severe or over a large area of the chest. A fall flat onto the chest from 2 to 3 feet up, a blow to the chest from a baseball bat or police baton, a kick to the chest wall, multiple blows at full force on the chest with fists, etc. should all be considered severe enough for the person to be monitored for 4 to 6 hours. If possible, that monitoring should be done in the ER. However, if it is not possible, the medic or an informed person should sit with the injured person, monitoring them for their symptoms for at least 8 hours. If symptoms develop within those hours, that indicates a major pulmonary contusion is impacting lung functionality and the person needs to be treated by emergency medical services as soon as possible. They may require supplemental oxygen, which medics just cannot provide. They may also require pain management with epidurals or nerve blocks, which again, medics can't provide.
We have
Yes.
a comment in chat that one of our attendees had a similar thing happen to them where they didn't find the issue until the second round of imaging when they couldn't breathe anymore.
Yep, they send them home. And I'm like, I'm a street medic. Why do I know this? This is, I have issues with not everyone in allopathic medicine. Obviously, there are excellent doctors, but it is an underfunded, very intentionally broken system that prioritizes money to the very few over care to the very many. Anyway, it is common for later complications of severe pulmonary contusions to develop days, weeks, or even months later, which generally include respiratory problems, including pneumonia. Medics who are also serving their communities as resistance health workers may be called upon to treat pneumonia later, which is covered in our other materials, or I can recommend some sources for you to learn how to handle pneumonia in your communities. Okay, any questions on that before blunt cardiac injury? No? The most commonly reported blunt force injury in emergency rooms is myocardial or cardiac contusion, two terms that are used somewhat interchangeably and without a clear definition or distinction. It is preferred by some in emergency medicine to just say blunt cardiac injury, which indicates a cardiac dysfunction, diminished function without dysrhythmia or hemorrhage, dysrhythmias and specific injuries caused by blunt force trauma. So this can be anything from rupture to valve injury to a myocardial infarction, which is a heart attack, to cardiac rupture, literally the heart burst. Something in it ruptured. The most common cause of blunt cardiac trauma is car accidents, but it can be caused by other blows to the chest. Although it is a myth in martial arts movie that there's like a 2-inch punch that'll blow up a heart, it is not actually a myth that a sufficient beating to someone's chest can damage their heart to the point where they die. Some medics are trained to suspect blunt cardiac trauma when a blow was specifically within the bounds of something called the cardiac box. The cardiac box goes across right here, comes down right over the nipples, and ends at the base of the rib cage. That's the cardiac box. And if you have an injury to the cardiac box, they're like, oh, you probably have blunt cardiac trauma. The cardiac box isn't an accurate model. It doesn't work. Because it turns out that you can have blunt trauma transmit to the heart anywhere in the cardiac cube. But nobody says cardiac cube. If it goes through the back between the shoulder blades or up through the rib cage on the side or over from the side of the body, it still affects the heart. So we shouldn't be using cardiac box. It was based on small studies primarily performed on penetrating wounds with really low kinetic energy with a fixed length. So like on stabbings with a knife, they were like, oh, the heart will be injured if it was in the cardiac box. But it doesn't work for things with higher kinetic forces like gunshots or blunt weapons like a baseball bat. If someone's hit in the back with a baseball bat, it still transmits the force to the heart. It still transmits the force to the lungs. So it doesn't work. Blunt heart injury is almost always primarily to the right side of the heart, generally the right ventricle, because it has a large exposure to the front chest wall, but injury may be to more than one chamber of the heart at once. Blunt cardiac injury can cause a sudden regurgitation of blood from a high pressure chamber or artery into a lower pressure chamber, basically causing a dysfunction in the valves or papillary muscles. This can cause immediate noticeable symptoms, especially with high pressure valves like the aorta, or it can take weeks or years for the damage to show. Any of you have long-term friends who are in martial arts? There are certain injuries that everybody knows who does any kind of like long-term fighting or impact sports that you don't see for years. One of which is the injury from repeat brain bruises, one of which is from repeat lung and heart bruises. So reasons to, really put some thought into whether you're going to be doing full contact sparring all through your 20s and 30s. Anyway, moving on. Even blunt trauma can burst blood vessels and cause internal hemorrhage. Even if the vessels aren't ruptured, sufficient blunt force trauma can cause an aneurysm or pseudoaneurysm at the time of the injury or later. Blunt cardiac injury may also rupture part of the heart, leading to heart failure. Coronary arteries may be occluded, dissected, or just spasm. Again, this can present as immediate symptoms, or the damage may go unnoticed for a long time and become a problem days, weeks, months, or even years later. A pulmonary contusion can trigger an immediate or delayed myocardial infarction, again, heart attack, which is caused by decreased or complete cessation of blood flow to a portion of the myocardium. People who have received blunt force trauma to the heart that is severe, valve injury, rupture, coronary thrombosis, dissection, etc., will require surgery. As a medic, you can't treat that. However, if blunt force trauma triggers a less severe dysrhythmia or myocardial dysfunction, it normally resolves after supportive treatment in the emergency room within about 24 hours. A lot of the time it doesn't need surgery, but it might. Signs and symptoms of blunt force cardiac injury: bruising on the chest, bruising on the back between the shoulder blades, which can also be a sign of spinal injury, bruising on the ribs, which can also be a sign of broken ribs, pain in the chest, difficulty breathing, tightness in the chest when breathing, sweating, pale or bluish skin, arrhythmia, lightheadedness, upset stomach, low blood pressure, signs and symptoms of internal bleeding, signs and symptoms of shock. If the medic identifies that a person may have a bruised heart, they should stay with them until emergency services arrive. If the person stops breathing, they may need to perform CPR, even knowing that it can worsen the blunt trauma to the heart. CPR can actually cause blunt trauma to the heart. I don't know if anyone ever told you. You can actually cause what we're describing, trying to save someone's life. They should monitor for the signs of internal bleeding, but also be aware that if the heart is bleeding heavily, the person is unlikely to survive. 10% of people who have blunt force trauma to the heart that has actually ruptured something, torn something free, actually make it to the hospital. Less than 10% survive even after emergency medical treatment. They should treat the person for shock while waiting for EMS. It is not the medic's fault if someone took a major blow to the heart and it burst something, it tore something, and that person dies. All you can do is the best you can do. Crush syndrome. Any questions before we do crush syndrome? Okay, I said during abrasions and lacerations that I would do crush syndrome in this class, so I'm going to. But I want to note that I kind of regret that. And I really think that crush syndrome belongs in the classes that we teach on medics going out into climate crisis events to evacuate people. Because generally that is when you would be the person responsible for treating a crush syndrome injury where a person would be pinned for multiple hours. However, I said I would talk about it in this class because it is a form of blunt force trauma and it does at minimum cause contusions. Okay, we'll blow through it here. There will be more detail in later classes. A crush injury is a kind of blunt force trauma caused by compressive force, which can happen in car accidents, work accidents, while rock climbing, etc. The compressive force may crush portions of the body, cause hemorrhage or even amputation, impair metabolism and circulation, and cause systemic problems. The longer a portion of the body remains crushed, the worse the systemic danger becomes. When a body part, like a limb, is crushed for a long time, typically 4 to 6 hours, the muscle cells begin to die. When the crushing weight is lifted, bleed, toxins from the dead muscles flood into the bloodstream. Crush syndrome causes hyponatremia, low amounts of sodium or high amount of water in the blood, hypocalcemia, low amount of calcium in the blood, hyperkalemia, high amounts of potassium in the blood, and acidosis, a high amount of acid in the body, which worsens shock. I point you to previous classes where we've gone in real detail on shock, the trauma triad of death. Yes, that is what it's called, where the body progressively gets colder and more acidic until it leads to death. That's what?
I just feel the need to share a particular piece of snark. This is, in fact, the only time that you do need to be medically concerned with purging your body of metabolic toxins.
Yes, it is. You are correct. This is the one time where people could say, but your body is full of toxins. What will you do with all the toxins? Okay, such problems put those affected at risk of even more health complications, including hypertension, irregular heartbeat, and/or cardiac arrest. These toxins can cause sudden cardiac arrest from high potassium levels, and that causes kidney failure. A classic sign of this is tea-colored or cola-colored urine. Minor crush injuries will be addressed in this guide, but more severe crush injuries are going to be addressed in our guide on wilderness crisis preparedness. Most crush injuries are to the extremities, as a crush injury to the core, neck, or head is generally pretty quickly lethal. They are often complicated by open wounds, fractures, and even degloving injuries on top of blunt force trauma. Extracting someone from a crushing object may be delayed, especially in climate crisis events. I want to caution you on looking up pictures of this, because I got to see someone's intestines and spine today. A crushed extremity is one of the signs and symptoms of crush syndrome. Also, the 5 Ps. Pain, diffuse and intense, exacerbated with touch, pressure, or movement. Paresthesias, numbness, tingling, and burning. Passive stretch, severe pain if the medic or other responder stretches the extremity. Pressure, the tissues feel as if they are pressurized. They are too firm when palpated. There's very tight skin over what feels like very swollen tissues. Pulselessness. In the later stages, when compression injury has become very dangerous, the extremity may lack a pulse. This doesn't always happen. It doesn't necessarily determine severity. Don't assume because a limb has a pulse that it isn't a severe injury. Contusions, lacerations, degloving, deformity, pain, ischemia, and hypovolemic or hemorrhagic shock. This is complicated. If someone has only been crushed for a brief period of under 1 hour and EMS is not available, so example, they were crashed in a climate crisis event and EMS is overwhelmed or cannot access the area, a medic can use lever and block techniques to remove the crushing object and then treat for other injuries like severe bleeding. I would say if you are in Raleigh, in Durham, in Chapel Hill, call EMS, have them come remove the object, have them treat, because there are things that they can do to save a life that we can't do. The only time I would say that a medic should make the decision to get someone out from underneath a crushing object is if EMS isn't coming in the next 2 hours. If EMS isn't coming within the next hour, that's when you might consider getting them out.
Potentially in a climate crisis situation, if the water is rising and by the time EMS gets there, they're going to drown.
If the fire is spreading in your direction, the water is rising, the smoke is billowing in your direction, 'cause it's actually smoke that kills more people than the fire.
Yeah.
There are reasons, and this brings us back to scene assessment. Are you safe to stay where you are?
If moving them might kill them, and leaving them there will kill them.
Then move them. If someone has been trapped for many hours, medical direction is needed before freeing them. The medic would manage the person for shock while waiting for EMS. EMS can perform fluid resuscitation to mitigate acute injury before extraction. This is one of the cases where having lots and lots of excess hydration purges toxins from the body, which they will actually do with intravenous hydration with an isotonic saline to maintain renal perfusion and dilute the toxic metabolites. Basically, they flush the body. They give you a bunch of saline to break up the toxic metabolites and stop them from overwhelming the organs. They can also give people like an IV of 5% dextrose and isotonic saline to help reduce hyperkalemia and sodium bicarbonate in half isotonic solutions to alkalize the urine. There's all kinds of things that they can do. One of the most important things about what they can do is that it changes based on how long the person's been pinned. I didn't go into all this detail because it's a lot of detail about how the doses change. But if someone's been pinned for 1 hour and someone's been pinned for 6 hours, their doses are different of how much of these flushing materials and whether some of them are used. So that's not something we know, but we do know I found them in the time I've been sitting with them, they've been pinned for 30 minutes. I don't know how long they were pinned before that. Or I saw it happen, they've been pinned for 60 minutes. So, okay. If EMS is not going to be able to reach the person within 4 to 6 hours and the medic has to transport the person to prevent their death, they need to use tourniquets to prevent reperfusion and severe metabolic shock. They can apply 2 tourniquets side by side near the injury, ideally before lifting the crushing object off the limb. If the object has to be lifted first, the tourniquets need to be applied as rapidly as possible, with like as little delay as possible, because that limb is going to flood the body as soon as there is no longer a pinning object. So ideally, you get the tourniquet on and then you lift the pinning object. Let's talk about tourniquets. We're going to try and be quick because I'm trying to be done on time today. For years, tourniquets were taught as either a never or an almost never. Even the American Red Cross First Aid and Safety Handbook from 1992 contained the information that one should never use a tourniquet. The common belief was and is that while a tourniquet could stop bleeding, it would result in the limb needing to be amputated. In a crush injury, there is a chance that limb will need to be amputated anyway. So just be aware that you can save someone's life but not necessarily save their limb. This misconception comes from when tourniquets were used to treat battlefield wounds in World War I, when transport to receive care took a long time to get people off the battlefield. A long period with such reduced circulation often leads to amputation, although not always. With rapid transport, this isn't the same concern. Even on the battlefield nowadays, medical transport is fast enough that tourniquets are widely used, and the military now issues tourniquets to all field personnel and has done since 2005. There is now a very large body of evidence that tourniquets are effective, they're safe, they have a relatively low level of complication rate, and that they save lives. In 2018, a research study by Teixeira and Brown found that the civilian pre-hospital use of tourniquets increased survival rates. There is no increased likelihood of amputation as a result of tourniquet application. We have been scolded for bringing up tourniquets in our classes and told that we're teaching people unsafe things. We've been told they cause amputations. They don't if they're taken off on time. They can be applied inappropriately when wounds aren't life-threatening enough to require them. They can be applied incorrectly and be ineffective, and they can be applied incorrectly and cause harm. Our answer to the second concern, that they can be applied inappropriately when wounds aren't life-threatening enough to require them, is that it's better to err on the side of caution if someone's in severe bleeding or has crush syndrome. The tourniquet won't harm them if they are transported by emergency services to an emergency department in a prompt manner, and bleeding to death would harm them. Our answer to the third, that they can be applied incorrectly and be ineffective, is to say that the same is true for any dressing or bandage, and the medic should be appropriately trained. But even a not quite tight enough tourniquet is likely to be more effective than simply pressing on a spurting artery with a gauze pad. Without proper placement, the person may die, but without can also mean no tourniquet, not only a badly placed tourniquet. Our answer to the fourth, that they can be applied incorrectly and do harm, is to, again, recommend better training. Okay. We are going to skim through some of this and point you to the class where we specifically taught tourniquet use on lacerations and abrasions. I will say that you get the device in place and then check to make sure that the blood flow has stopped. In the case of a crush syndrome, it's the same thing. You get the tourniquets in place, you get them ratcheted down, you get the object off, and then you make sure the person is no longer spurting blood from that limb and that it does not appear that blood is moving between the two things. Tourniquets are only ever applied to extremities and never to the neck, torso, or groin. It needs to be placed on bare skin. If you can't get all of it on bare skin, cut, tear, or pull away clothing as much as you can to get as much contact between the tourniquet and the body as possible. It needs to be placed 2 to 3 inches above the injury, between the heart and the injury. So let's say that the falling object is here, then the tourniquets would go here. It needs to go between the injury and the heart, not below the injury. That doesn't help. Does that make sense? Let's see. Tourniquets hurt. If it's been ratcheted down appropriately, it is going to hurt the person. So is them being pinned and developing crush syndrome. But just be aware, they hurt. I've had people tell me, I didn't deal with this, but I've had a medic who was teaching me tell me that they had to keep batting someone's hand away from because they kept trying to loosen their own tourniquet when they were bleeding because it hurts. But it is necessary. Tourniquets used for more than 2 hours and less than 6 should be converted to an alternate method, generally if possible, like wound packing or hemostatic pressure dressing. If you as a medic are going to be serving in environments where transport to emergency department and removal of the tourniquet will be delayed by over 2 hours, then you need to train in something called tourniquet conversion, which is where you actually learn to take the tourniquet off and put a different bleeding treatment in place. However, the exception to this is crush syndrome, which we're talking about today, where the tourniquet has to remain in place until a medical professional can remove it, as it was placed to prevent crush syndrome from causing acute kidney injury. The reason that you don't leave a tourniquet in place for longer than 6 hours
is that you give someone
crush syndrome. You give them compartment syndrome, not crush syndrome, but they are very, very similar in that you've cut off blood flow to the limb and toxic metabolites from the tissues breaking down accumulate in the limb. And if you take that tourniquet off after 2 to 6 hours, that floods the body with all of those toxic metabolites. But additionally, with the tourniquet, cutting off that blood flow, you can eventually lose the limb. But with crush syndrome, those toxic metabolites are in there, and if you take the tourniquet off, that floods the body. You're not just concerned with the bleeding. So it is the one case where you would leave the tourniquet in place until the person is evac'd out, which is why I said that this is really meant more for our wilderness classes and is probably more detail than we need here. Okay. If ever you put a tourniquet on someone, you need to mark on it what time it went on them. This is vital. Don't expect yourself to remember. If you're in a crisis situation, you may think, oh, I'll know that I put that tourniquet on at 1:15. And then you get a couple hours later and you're like, wait, was that 1? Was that noon? When did I do that? Just write it on it. It has a place for it. All tourniquets are generally issued with a place to write it. Carry an indelible marker with you. Okay, any questions on that before we move on to managing hemorrhagic shock? Okay, hemorrhagic shock can occur from blunt force trauma. We talk about internal bleeding when it comes to contusions. Contusions are internal bleeding. So what we really mean is heavy internal bleeding, excessive internal bleeding, internal hemorrhage. Hemorrhagic shock can occur from both external and internal bleeding. A factor in how hemorrhagic shock affects the body is how fast it happens. A person can donate 1 pint over 20 minutes and not necessarily feel adverse effects from doing so, but if that same amount of fluid loss happened over a minute to 2 minutes, they would experience hemorrhagic shock. If the average American AMAB adult person has lost just under 1 liter of blood, they are likely in hemorrhagic shock. This is the equivalent of 2 large beers poured out on the ground. For an average American AFAB adult person, the number is lower at approximately 750 milliliters. This is the equivalent of 1 bottle of wine poured out on the ground. Because infants and children have less blood than adults, they experience hypovolemia, low blood volume, very rapidly. A 1-year-old child has approximately 2 pints of blood in their entire body, so they may suffer from hypovolemia after a loss of only 3 to 6 ounces of blood. That's less than a glass of water. If you have a standard kitchen glass, most of those are 8 to 10 ounces. Keep in mind that the average glass, I already said that. So it should be noted that the symptoms of shock are not a perfect guide to assessing blood loss severity or determining treatment. Symptoms vary, and no system of assessment is perfect. The signs and symptoms of shock can be measured using a 4-stage system that is detailed in our guide on abrasions and lacerations, or using the compensated and decompensated model. The compensated and decompensated model is best for rapid assessment in more chaotic environments. Compensated shock is the phase of shock in which the body is still able to compensate for fluid loss and maintain adequate blood pressure. Decompensated shock happens when the person's body is unable to compensate for fluid loss and cannot maintain the brain and the vital organs. Compensated shock symptoms are anxiety and a sense of impending doom, agitation and restlessness, weak and or thready pulse, rapid pulse, cool and clammy skin, white or gray pallor, especially with bluish or purplish lips, shortness of breath, nausea, vomiting, thirst, and normal blood pressure. Decompensated shock looks like confusion, altered consciousness, possibly nonverbal and unresponsive, labored breathing, thready or absent pulse in extremities, ashen mottled or bluish or purplish skin, and low blood pressure. The first steps of treating hemorrhagic shock are the same as in treating any injury. Scene assessment, ensuring the safety of the medic, ensuring the safety of the person, ensuring the safety of the bystanders. Standard precautions for bloodborne illness should also be met if at all possible. If the person is conscious, the medic can continue with patient assessment in a calm and compassionate fashion. If they are unconscious, the medic needs to check for airway constriction and breathing. Heavy bleeding has to be stopped before attempting CPR. If the person is conscious, the medic can help them get into a supine position, flat on their back, looking straight up at the ceiling or the sky. They must not allow the person to eat or drink something, even if they're very thirsty. Shock causes severe thirst. It's a myth that giving them some chocolate or a cider or juice or something will help them feel better. The only thing that that's good for is emotional shock. And even then, if they're hyperventilating, it's a choking hazard. The person should be kept warm with a shock blanket while waiting for emergency services. Most external hemorrhage can be halted with direct, even pressure. Unfortunately, most internal bleeding can't be stopped with firm, direct pressure. So it's more of a case of keeping somebody stable and warm until EMS arrives. Okay. Before we get into herbal treatment for bruises, do we have any questions on that? What would be a sign, do you think, that someone has rapidly spreading internal bleeding? We talked about the signs and symptoms earlier of internal bleeding. What would be a sign that it's getting worse? Anyone?
Spreading visually.
You can see it spread sometimes. If you think about a bruise, generally it takes a couple days for it to grow, right? You get a bruise, first it's red. Then it's painful, it's a little swollen. Then, 1 or 2 days later, it turns dark. Then it gets darker for a few days, and then it starts turning yellow or brown or fading, right? If that bruise goes through that process on speed run, if you watch something go from red to redder to purple and yellow and green, that is not a good sign. That is spreading very, very fast. Blood accumulating under the skin is another sign. Have you ever had a bruise actually swell up on you? Any of you? Okay. If that happens really fast and in a big area, again, not a good sign. Now, I showed some pictures of big internal bleeding bruises earlier. Think about how fast that might happen on a person's body. If you see that rapidly happen, that's generally a sign of severe internal bleeding. Okay. Herbal treatment for bruises. Panax natto ginseng radix. A retrospective study on the survivors of the Great Sichuan earthquake who were diagnosed as having multiple rib fractures and pulmonary contusions found that those given Panax natto ginseng radix alongside their conventional treatment had lower pain, shorter duration of ventilation, and needed less analgesia administered and had a shorter hospital stay than those who were given the conventional treatment alone. It does affect how medications are broken down in the liver, and it interacts with blood thinning medications like warfarin. So I'm actually really surprised that they gave it to people with multiple rib fractures and pulmonary contusions. And I don't know that I would be willing to, as a medic, give someone with a pulmonary contusion Panax ginseng.
To be fair, this was a retrospective study, so it was probably people got treatment from their traditional medical doctors and then got conventional treatment alongside it.
Yeah. Comfrey, Symphytum officinale, common comfrey, true comfrey, boneset, and nip bone. If you have any herbalists in your family, I would bet money that they've used comfrey. It is one of the most commonly used traditional plants in the Western medical tradition. It was used traditionally to treat injuries for thousands of years. Recent studies have verified that its topical application is effective for the treatment of wounds, reducing pain when moving, pain at rest, and duration of healing. I don't know if you actually want me to read off all of these studies, but I will say that multiple randomized, multi-center, double-blind studies performed on hundreds of people found that a 10% active ingredient cream, which amounted to 25 grams of fresh herb per 100 gram of cream, reduced pain, helped with healing, significantly improved the range of motion, how people respond to palpation, impairment of function, and sped up the healing of edema and hematomas by very large margins in both adults and children. So I found like one of these was done on 196 children, one of these was done on 163 people, one of these was done on 203 people. And then another found that a cream containing 35% comfrey root extract also had these effects. So somewhere in the 10 to 30% range of the comfrey to the other ingredients is needed to have these effects. Comfrey may be unsafe to take by mouth due to the presence of pyrrolizidine alkaloids. There is some debate on the studies that said comfrey was unsafe to take by mouth. I would encourage, if you are an herbalist, that you look into that yourself and you make an informed decision, and that you and your clients make informed decisions together. But I will say for now that it is not recommended that people take high frequent doses because they can cause liver damage, lung damage, and cancer. But really, comfrey is best used externally anyway. But it shouldn't be used on broken skin, as it can be absorbed through to the bloodstream. High-dose topical applications should not be used on the skin for longer than 6 weeks, again, because pyrrolizidine alkaloids can actually be absorbed through the skin, and they build up in the body over time. So you want to take breaks. You don't want to be using this all the time. If you are a martial artist who is always getting bruises, that is not the cream for you. You want to pick something that doesn't build up in the body over time. Okay, how many of you have ever put arnica gel on a wound? I know I have. Arnica is an effective anti-inflammatory, antimicrobial, antioxidant, and immunomodulatory natural treatment. Both ingestion of arnica and application of topical arnica have been verified in clinical trials to reduce the pain of bruising from injury and from surgical operations. Studies have found that it is better tolerated compared to the commonly used medications for post-operative pain, such as diclofenac. It may also reduce opioid intake for pain management after surgery. A 2020 systemic review has found that arnica may reduce ecchymosis, discoloration of the skin caused by bruising. A 2021 review of multiple clinical trials found that arnica was an effective adjunct medication for pain management. High and long-term dosages of ingested arnica may be contraindicated, as it can cause diarrhea, vomiting, nausea, and internal bleeding. It should not be combined with blood-thinning medications like warfarin. It should not be ingested by pregnant people who wish to remain pregnant or by nursing people. Topical use of arnica may lead to contact dermatitis in some people, so do a patch test. Test it in a small area. Make sure you don't apply it to a large area until you confirm that it isn't causing contact dermatitis. If a person is allergic to sunflowers or marigold, it's likely that they are also going to be allergic to arnica, so avoid the use in that case. White willow bark, Salix alba, is an analgesic with anti-inflammatory, sedative, hypnotic, and febrifuge properties. It has been used to treat pain for thousands of years. Willow bark is possibly safe when used for up to 12 weeks. Salicin, the phytochemical primarily responsible for its pain-relieving effects, can be used by adults in doses of 120 to 250 milligrams of salicin by mouth daily for up to 6 weeks. It takes approximately 1,360 milligrams of standardized willow bark extract to contain 240 milligrams of salicin. This is my fancy way of saying that all the people who go, you can't take salicin for longer than 6 weeks without causing really severe, yes you can, because it's a dosage thing. But willow bark's level of salicin varies wildly from plant to plant and even through the seasons. And so for that reason, we have listed the dosage of the standardized extract rather than the hot water infusion. White willow bark might cause diarrhea, heartburn, and vomiting in some people. It can cause itching, rash, and allergic reactions, particularly in people who are allergic to aspirin. If a person is allergic to aspirin, they should not take white willow bark because aspirin is derived from white willow bark. It is contraindicated for people with bleeding disorders, clotting difficulties, kidney disease, or who are on blood thinners, diuretics, or other salicylates. People should check specific contraindications for everything I'm listing. Specifically, there's a laundry list of things that you cannot combine white willow bark with, so be careful, make sure you know. Valerian, Valeriana officinalis, is a relaxant sedative nervine which calms the nerves and antispasmodic plant that can help injured people relax and sleep. Valerian has most often been used by adults in doses of 300 to 600 milligrams, the equivalent of 2 to 3 grams of dried herbal valerian root soaked in 1 cup of hot water for 10 to 15 minutes, and that can be taken by mouth daily for up to 6 weeks. It tastes awful and it smells a lot like gym socks. So Ian disagrees with me. He thinks that it tastes wonderful. He likes the funkiness. I'm not a fan. I prefer wild lettuce to help me sleep, but to each their own. It can cause drowsiness, gastrointestinal upset, headache, and heart palpitations in some people. People with ADHD may develop insomnia or overstimulation from ingestion of valerian. It should not be combined with GABAergic agents. It should not be combined with barbiturates. It should not be combined with other sleep medications, alcohol, surgical anesthesia, or medications that are broken down in the liver. And people should, again, check their specific contraindications. Okay, so that's herbal treatment for bruises. I say herbal treatment for bruises partially because I am an herbalist and I believe in using herbalism for activism and to serve our communities, but also because as street medics, we're not allowed to dispense over-the-counter medication. But we are allowed to dispense herbal medication that's made for us by a local herbalist. Go figure. Okay. Any questions on everything we blew through tonight, from chat or from anyone present? Questions, comments, concerns? All right, well, I will put a couple challenges to you. I want you to think as a street medic about the situations in which you might encounter someone who is bruised, someone who has a contusion, okay? And tell me one. Ian.
Someone has fallen, either on the street or at a protest,
Okay.
or in a fight.
So somebody fell over.
Yeah.
Face first or back first?
Face first is more common.
Okay, face first. Where would you expect to have bruises? Anyone?
Forehead.
Forehead if the head hit, okay. Palms, forearms, maybe elbows, knees, whatever smacked into the ground, right? What other injuries might be present if somebody fell and hit that way?
Abrasions, lacerations, possible strain, sprain, or fracture, possible head trauma.
Right, if they hit their forehead on the ground, that's probably going to cause some kind of a head trauma, like not only the contusion, but how hard did they hit? If they hit arms first, you might see fractures go all the way up the arm, could dislocate the shoulder. They probably have abraded their palms. Didn't you, as a kid, ever fall that way and take the skin off your palms, take the skin off your knees? So a lot of the time in a fall, your bruise is going to be combined with other injuries. And you have to be looking for those when you're looking at the bruises. What's another thing you might, as a street medic, encounter? Someone has been injured, they have bruises. What mechanism of injury caused it?
Hit by a car.
Hit by a car. You stop, right? You put out your flashers to indicate go around us. You go, you call 911, you put that down so that you can talk to the EMS while you're getting this person out of the car. They have maybe a big contusion from the seatbelt across here, from the steering column. They hit it, it hit their chest. Maybe the airbag came out and that also bruised their face, bruised their nose. They've got a bloody nose. Maybe they hit their head. So you're looking here at a lot of blunt force trauma, but you're also looking at potentially the trauma of rapid deceleration. Whiplash. Right? You're looking at all the force of the car accident that managed to make it past the crumple zones and transmit into their body. So we're looking at a pretty serious injury potentially in that case. Depends on how serious the car accident is. A lot of those images I shared of abdominal trauma that was severe on the abdomen, those were seatbelt injuries. It is still wise to wear your seatbelt. Every time I teach this class, I've been, so should I not wear my seatbelt? No, because flying through the windshield is worse. Like,
Climbing back through the windshield is even worse.
We have a class coming up on anti-abduction, being thrown to the ground. Being very careful about how I talk about this because this is going on YouTube. You as a street medic might end up helping someone who has been thrown to the ground by people who are detaining them. Might deal with someone who's been thrown to the ground by someone who's been who's beating them, right? Or kneeling on them. You're talking about really complicated injuries there, where the bruises are layered with other things, fractures, lacerations, concussions. That gets complicated really fast. That's why when we talk about this, we talk about that head to toe assessment and not just looking at a bruise and going, oh, it's a bruise. That's all. Bruises are often indicative. They tell you where an injury is located, but they may not be the primary injury. Where you can guess at a primary injury is going back to that mechanism of injury and going, okay, I know these forces affected a body and I can surmise that that would lead to these injuries. That's why I'm trying to play this game with you.
Someone added that there could be injuries to the collarbone as well.
Absolutely, yes.
Yeah.
Collarbone, car accidents can be pretty nasty in the forces that are transmitted. So can being thrown to the ground, being beaten. So get into the habit as a street medic of assuming that all of these things we're covering are interrelated and that you will not, there are cases where you will have an uncomplicated injury, right? Recently at a class, we had a person get a minor cut from a pocket knife, right? We were cutting a zip tie off someone. They got a minor cut. I know what that is. I don't have to do a head to toe assessment. I can treat them right away. But it's not often that simple when you're talking about bruises in particular. They are often a layered thing that come with other injuries, because to get a bruise, you had to have force transmit through a body. Okay, so I said I'd share a funny story, which I will do, and then we'll be done.
Turn off the camera first.
Let's go ahead and turn off the YouTube one. I will just say, please remember to like and subscribe and come find us on Patreon, and all of our content for this, including all of our notes and the PDFs and the EPUBs, are posted there for free.